Hello everyone and welcome to today's webcast. My name is Peter Dye and I am a Senior Program Coordinator here at CPCA. I am thrilled that you are able to join us today for a webcast titled Building the Business Case and Return on Investment for PCMH. Our speakers today are Charla Parker and Patricia Talbot, who are both CPCA Practice Transformation Coaches who have assisted over 100 sites to receive NCQA PCMH recognition. Today's webcast builds off a recent report done by the National Committee for Quality Assurance. NCQA engaged Milliman, the world's largest providers of actuarial services, to provide the first comprehensive look at the business implications for earning PCMH recognition. Charla Parker, one of the speakers today, was a key informant to this report because she helped an enterprise-wide medical foundation standardize reporting across all sites in 3 different states to achieve PCMH recognition. The speakers today will go over how to calculate return on investment using a provided template, identify how PCMH can reduce physician and staff burnout, and review how to align PCMH recognition with quality improvement and HERSA requirements. Charla, you have the floor.
Thank you, Peter. I noticed from the attendance list that we have a mixture of seasoned applicants who have submitted under 2011, 2014, and now working on 2017 annual renewal. And we also have some participants that appear to be brand new to the process. So I think the newcomers have an advantage that we didn't have when we started this process back with the 2011. At that point in time, it was PCMH was new. HERSA said we want community health centers to try it. Here's the goals, the triple aim. And we went off on hope and expectation that this would work. And now what's changed is since the programs have been in place, some now for 6 going on 7 years, you can go to the next slide. We now have research. So NCQA engaged Milliman to do research on a number of agencies that had gone through the process. Next slide, please. And I had the opportunity to be a contributing editor to the advisory group. So I had a chance to help develop the survey questions and provide some background since I have coaching experience both in the community health world and with a large private multidisciplinary practice here in Sacramento. But what's interesting is they showed that all payment models had a positive return on an investment from 2 to 20%. Now, most of this study is focused on large health systems, so there isn't as much specifically focused on the community health centers. But if you download the paper, you will see toward the back of the study, there are more citations for community health centers. Next slide, please. And so the HERSA has several papers that have been published each year. There's a document that looks at the cost benefit, and this particular researcher seems to have published 2017-18, and now I found a 2020 document. But what I thought was relevant in this citation is the access increase. As you know, access was in the beginning. If you didn't pass access standards, the reviewers didn't even look at the rest of your application. So I thought that this was an important number to include in a return on investment study. And then if we go to another citation in the next slide, you can see this is the same researcher that looked at from a different perspective. Again, this was for HERSA. And what he showed in this study was that having the PCMH infrastructure increased the outcome studies on the clinical performance metrics. So the HERSA metrics that you're required to report on showed an improvement. And what it did show, it wasn't just a one-time improvement, but the longer that the PCMH infrastructure was in place, the greatest the improvement. So the value of the PCMH infrastructure is putting in place ongoing quality improvement activities. And then next slide. So we've seen you can increase visits based on the research. You can increase your performance on your clinical metrics. And so then how do you equate those positive outcomes to incomes? And I find in working with health centers, particularly those new to the process, they aren't fully aware of all of the quality awards. They tend to just look at, well, how much would we get for PCMH recognition? And what I'm inviting you today is look at not PCMH recognition as a standalone award, but the preparation to go through the recognition application also requires you to put these other systems in place that then make you eligible for these other quality awards. Next slide. And so what I did, I just went to that award website and I took a screenshot and de-identified the health centers so that you could take a look across the board, see at the top one, they got $30,000 for PCMH recognition, but look, they got monies in several other quality initiatives. So it's not that PCMH is separate from, it is sort of the platform or the infrastructure from which you can build to attain other awards. And then Peter took this and expanded it to show you a historical run. So he will give you a bigger picture detail in a slide later down.
Yeah, Charlotte, this is Patricia. I would also like to note that there's a lot of zeros on this, and so there's a lot of money sitting there waiting to be had.
Yeah, and so that's what we're hoping to convince you today, is that if you have the infrastructure or if you're beginning the infrastructure, don't just look at the amount of award that you can get for achieving recognition. Look at how you're building the infrastructure to be able to collect monies in multiple categories. And just so you're aware, NCQA maintains a directory of resources and incentive programs that gets updated regularly, and it is sorted by state. So it's really easy to just click and see where you might be able to reach out for additional compensation. And California Primary Care Association has some tools on their website, but I believe that the LA Care Health Plan, multiple health centers are involved in that, as in the Central California Alliance. And so there's an additional per member per month reimbursement that might be available on top of your regular HERSA fee. So this is just where you can look for additional information. Okay, next slide. And then I am just finished attending 2 webinars earlier, and changes in Medicare reimbursement and changes in quality initiatives, and reinforced that in addition to the triple aim, that the 4th aim or the quadruple aim is now really focused on provider burnout and provider satisfaction. And so we're all aware of the shortage of primary care physicians. So more attention is being paid to being sure that the physicians are happy in their medical home. And what the new studies are showing is that there is definitely a link to reduction in clinician turnover in communities that have patient-centered medical home. I'm working with a medical group that went from almost a 40% turnover in a crisis before they started the PCMH process, and 5 years later, they're at 4% turnover. So I have personally witnessed the positive impact that creating the integrated physician-led care team can really make a difference. And the research averages it's 2 to 3 times the salary when you lose a physician. You have the recruitment costs, you have the ramp-up costs because a new clinician isn't going to be fully productive at the beginning, and most of the time there's a gap between when the leaving physician has left and the new physician is coming. And so that's why they estimate it's 2 to 3 times. And there are a number of studies on physician burnout, but I thought that this from the JAMA journal was probably the most relevant, and it also will give you links to other studies on physician turnover. And so that's the fourth aim of the quadruple aim. Next slide. So in summary, how do you go about just categorizing your return on investment? Well, the obvious, what's the potential you could get if you went for all of the HERSA bonuses and not just the PCMH incentive? And do you have the opportunity to get other payer incentives? And I know there's some demonstration projects with CPCA where the opportunity might exist. And then where people sometimes panic, oh, it's going to take so much staff time. How are we ever going to get this done? And so realistically, how much staff time does it really take? And I'll discuss that in a minute. And then what else does it take? So initially, I think people looked at, well, we can maybe get $35,000 in a HERSA bonus, and that would hire a full-time coordinator. And so that would be worth that if we can offset that cost. And so sometimes that's how we started. It was just a person to coordinate the application process. And then finally, I think we need to add to our potential for reducing clinician turnover and add that into our ROI. And so what I did, I put a little spreadsheet together with Excel, and Peter sent a copy of that, and I will walk you through how to complete it in the next slide. So I just took the assumption of 10 clinicians with a panel of 1,500 patients and 15,000 population because it was easy math to do. And what I have found in my experience that most sites who maintain their HERSA status already have quality initiatives in place. And so typically what's needed is a project coordinator. And I have found in many sites that the project coordinator is someone who has already been experienced in coordinating a special funded grant program. And so they know who the players are in the organization, they know how to access data, and they're used to filling out reports in order to meet grant requirements. And so I figured about a half-time FTE because of the other half-time they're probably coordinating another program. And so if you put their salary in and then half-time would show that it was just, I just lost my screen. There, showed the annual amount. And while I find most community health centers have had care coordinators, particularly around discharge or complex care management, for example, in the PHASE program, that sometimes additional FTE is required because the NCQA documentation requirements are more time-consuming than the process they used before, which was just a follow-up phone call with a note in the chart. And so I think probably one RN per 3 clinics could probably tackle those additional documentation requirements to take the work they're doing into that next level of formality. And the same with the referral coordinators. Most sites are already coordinating referrals, but to get PCMH recognition, there's additional documentation required to close the loop, i.e. to prove that not only was the referral made, but that the patient got to the appointment and that the consult reports got back to the primary care physician. So sometimes it's that additional documentation. And so just on my experience, this I think is probably the typical additional cost you might have on staffing to really implement and maintain the PCMH infrastructure. Next slide. And so then if you look at what your staff cost is, and then what are your possible quality incentives, I just randomly plugged in some numbers based on those examples that I showed you earlier and said, well, this clinic could probably go for 5 incentives, and the total dollar amount for that is shown here at $115,000. But maybe they have a small contract with, say, Partnership Health Plan, where they have a few patients that if they meet certain criteria, they can get an additional $3 per member per month. So I threw in that little incentive value. And then the next slide. And then the one that I think typically is not thought about is with the increased efficiency with the whole care team and emphasis on increasing new patient access. This is where the one study showed that the average community health center could get 163 new patient visits per 1,000. So that would equate for a practice of 15,000 to 2,445 patients. It took an average reimbursement rate of $175. And wow, you're surprised at how much additional revenue is generated from new patient visits. So if you add your HERSA, your per member per month, your revenue increases, you're now looking at potential increased revenue of $578,875. And we projected additional staffing expenses of $137,000. So if you subtract the difference, then you see what your net income is, and then you can see what the return on investment. But if you want to take it a step further and then add in reduction in your physician turnover. So I said one physician didn't leave. So we had 10 physicians, and this one physician decided, no, I like having an RN follow up with my complex patients and a referral coordinator. I think I'll stay. And so the average is 2 to 3 costs, so I used 2.5 times the annual salary to show a savings of almost $500,000. And so if you added that in, then you have a potential net change in income of $939,000. So that's just an example of how you could walk through and just plug in the numbers on the spreadsheet to come up with a potential return on investment for your health center going through this process. Next slide. So just the summary, be sure you include all possible incentives. Think about the additional staff that you would need versus current staff that can take on additional documentation roles, and then really look at the impact of physician burnout. And remember, recognition is not the end goal. The goal is to use the PCMH infrastructure to help you meet your clinical and operational goals. And so next up is my colleague, Patricia, who's going to talk about how you can integrate the preparation for PCMH recognition with meeting your HERSA requirements and how you can use a coach to help you on your journey. It's all yours, Patricia.
Hi, thank you, Charla, for that. That was really interesting and very informative. I certainly appreciate it. So my part is of talking about how we can connect the HERSA dots to the patient-centered medical home recognition process. So I'm going to start with the fact that I would think a lot of us have the same question. Why is HERSA so interested in helping us become recognized? And I thought of the things that that why they might be interested in helping us be recognized. And then I called HERSA and had a really great chat with a PCMH person there. But I went through the whole process with her, and she agreed with these, and she added more, which I will say here. So it does improve quality, and they can actually see that through your UDS reports. The fact that they're improving the performance measures are improving. They're seeing improved patient satisfaction. We're optimizing healthcare delivery practices. We're improving our outcomes. We're meeting and exceeding Healthy People to 2020 initiatives already. And I think it's they're proud of their this national standing that they have invested upon. So I think they're looking at their goal is 70% of all health centers in the nation are recognized. So at this point, 77% of all the health centers are recognized nationally. And I actually got this information that came from the health center data depository. They actually reported these numbers at the 2020 justification of estimates for the Appropriations Committee. So all the things that we do all the way up to congressional review is what happens with us. And they're so proud, and we're so proud. We have exceeded their percentage nationally. In California, if you look at the information about the PCMH awards, I pulled the 2018 awards. There was 117 organizations, and we have 177 FQHCs. That's the number that Peter has given me. So that means we only have, not only, but it's good, 66% of our health centers are recognized with one of the three bodies that HERSA does support. So we have a little ways to go to get up to the national standard, but certainly get to the 70%. That would be awesome. So most of you know that the HERSA does pay for the application and the licensing of the physician process through all three of the bodies, and particularly NCQA, and that there is, if you just Google HERSA NOI, you will get that page right up, and it'll show you how to go through the electronic handbook to process your NOI. That it takes maybe, they say 2 weeks, but I usually see 3 or 4 days at the most. You just go back to EHBs to see if it was approved. They also send an email to the person in contact in the EHBs to let them know it was approved. So that is a really good place to start if you haven't started there. Next slide. And Peter, if you could tell us about what this slide's about, California performances.
Yeah. Before I go to the California Quality Awards, just to piggyback off of the NOI process, so HERSA does also pay for the annual reporting fees. If you're due for annual reporting, I know 2 of the health centers in the program are due next year. You go through the same process. You submit an NOI, and they'll give you a special discount code where you could apply to cover those costs. So as Charla and Patricia talked about earlier with the Quality Improvement Awards, CPCA actually tracks this, and the BIPIC Office of Quality Improvement has been investing in patient-centered medical home recognition since 2016. They've always supported paying the costs and application fees, but they've started to award health centers who achieve this recognition since 2016, and again for this year. They put out a PCMH bulletin earlier this year to confirm that, and typically the process is to update the status of your health center and the PCMH in July. So right now they're going through UDS data and everything that was submitted to them to distribute the Quality Improvement Award. So you should stay tuned for that announcement this month. And the highlighted portion is just the trajectory of PCMH quality awards over the years. So as you can see, it's been improving.
Peter, I would like to, before you go on the next slide, I would also like to interject that we have until, well, they actually start looking at and asking health centers if you hadn't sent information to them in July 1st. But I would certainly, if you wanted to be recognized and get these bonuses for next year, my recommendation is to get approved and recognized about a month before. So you're looking at like June 1st or May 30th. So if you're in that process now, that is, and you're interested in the incentives, that's kind of where you would want to hit your timeline. Thank you,
Yep.
Peter.
Yep, I totally agree. Thank you, Patricia.
So what is pretty awesome is that they're now giving these recognition badges. So here's HERSA's improvement badges from all the things that Charla and Peter have shown you. And each one has, you can see the gold one. It's like having a gold card, I guess. And NCQA has a recognition badge as well. And I see these now all the time. I see it in marketing. I see it in websites and information given to patients. It's certainly something we write letters to our support persons like our funders, our IPAs. So it does hold a real nice cloud over the health center showing that you are a recognized body. So HERSA, as you know, we're trying to help and coach through your recognition. At the same time, many of you are having site visits. And so, there's a way to be able to use your protocols and guides or your UDS report to meet the PCMH standards. There's so many of them. I wish I had a list of them that you could actually look through, but there's 98 different elements in the guidelines for HERSA, and there's 40 core criteria and 60 electives criteria with 83 elective credits available. And so what you do on the HERSA side, or vice versa, what you do per PCMH can really support the being in compliance with regulations. So when I say you could use a UDS report, UDS report is, kind of goes over the whole organization, but it takes pulling data to meet the UDS report. So many of you already have the drill down from every site from your UDS report. Many of those can be used for the recognition process. So I'm just going to give you an example. So for patient access, which is AC 01 to 14, look at what your organization has done, policy procedures for HERSA. And if you've had a recent site visit, most likely they're going to be updated. So that's accessible hours in operation, after hours coverage, services and staffing. So for TC 01 to 09, that's team-based care and practice organization. In the HERSA, there's a process of quality improvement, program data reporting, and staffing that you'll find information, or vice versa. For KM 01 to 20, knowing and managing patients, you could use that drill up towards the UDS reports, your quality improvement reports from, everybody has to do quality measures for HERSA. So you can, I would not, unless you wanted to, reinvent the wheel that you already probably are doing. And I've always said NCQA recognition is when you give them something, you're showing off what you already do, and you want to be recognized for what you're already doing. So there's things that you're already doing that you can share with NCQA for this recognition. Okay. CM 0109, care management and support. In the HERSA, you can find this under the required and additional support. They require referrals, a whole policy and procedure that you are looping back, your collaborative relationships, which is the support part of CM. So for CC 01 to 21, care coordination and care transitions, you can find that in the HERSA process for required additional services, the referrals, the relationships, program data reporting, etc. And QI 01 to 19 is performance measures and quality improvement. And there's a big process with HERSA through the quality improvement. They actually now are coming on, if you haven't had a site visit yet, they are doing diabetes as a quality improvement process where they're helping doing TA for that. And you already have that, and if you already are working on that for HERSA, you can certainly share that with NCQA. Just as an example, in PCMH, they'll ask you about maybe, if you have ability to, what do I want to say? You have ability to credential or know that your physicians that you refer are credentialed, and their HERSA already ask you to make sure their credentials and their contracts that you have directly with them. So, and you may not know that because you're not in the contract world in your health center, but they should be there. Your site visits are required to have them there. So you can certainly share that piece and portion of that contract with the requirements for PCMH. So there's all these other quality improvement reports. We've already talked about UDS, the 330 performance indicators and evaluations, IPAs, they ask you, they come in, they have to review your organization. So they are looking for their HEDIS reports, which you can certainly use. There's state and regional grant reporting that you do if, for those particular individual grants. There's the quality improvement measure, quality measurement and improvement worksheet that you can do. It's 30 patients for reporting, and then it should have been 2018, the quality measures crosswalk for PCMH 2018, which you have, we have sent to you, which gives you the different places where they'll accept those reports, which is great because you don't have to reproduce them for NCQA. So this is what the quality measure crosswalk looks like. The last one we had, and I've actually reached out to NCQA to see if we could get an update. This one was updated July 2018. It's the last one that I can find.